To properly study the perimetry map has been divided into different zones, and each zone represents a special map and special information we can extract from that map. The reason why that, because by the end of this reading of this map, we should be able to determine the type of the test and the strategy and the type of the machine used, and which eye, right or left, and is your test is reliable or not, and is your test normal or not. All these questions should be answered after reading this map. So it is very important to go through each sector of this map and extract the information you need from it. This slide shows the initial informations you will find in the top of the printout of the perimetry paper. You will find the demographic data of the patient, that is the date of birth and the age of the patients. And also you will find the visual acuity of the patients and the refraction of the patient, and if there is any addition of lenses in front of the patient or not, and the pupil size, which is very important. And then this box shows the strategy. What type of strategy are you using? The standard threshold strategy, or CETA standard, or CETA fast, or CETA faster, and so on. And the last one shows the reliability indices. This is the fixation errors and the fixation loss, the false positive, false negative, and so forth. And one of the main important points that you should always look for is the foveal threshold. Here, you will find the location of the foveal threshold. You'll see it here, the foveal threshold. So this is very important because this corresponds to the visual acuity. So if you find a very good foveal threshold with the poor visual acuity, this indicates that there is something else in the patient's affecting his vision. So this shows the reliability indices. This box shows the strategy that's used, and then the pupil size and the visual acuity and the refraction, and the date and the age of the patients. Here we will speak about the first zone in the perimetry map. That is the zone that contains the demographic data of the patient. That's the patient name and age. And the most important is the age of the patient. The date of birth is very important to compare it with the normative data. And another thing is the pupillary diameter. Between 3 to 4 millimeter is an ideal. Less than 2 millimeter will cause generalized depression of the sensitivity of the retina. And another important point is the refractive error. Refractive error should be corrected, especially for the near correction. If the patient beyond the age of 40 and he has presbyopic elements, so he should wear the near corrections. And also, if the patient has any significant refractive error, he should wear the glasses before doing the perimetry. 3 to 4 millimeter pupil size is optimum, and less than 2 millimeter will cause generalized depression. The second zone is the reliability indexes, and it is regarding the false positive and false negative and fixation errors and the gaze tracker for the blind spot. So in this square, you will find all the data, especially the foveal sensitivity. Here is the foveal sensitivity is very important because it correlates with the visual acuity. So all the indexes you will find here in this corner. We will speak next slides in details about each one regarding the false positive and negative and its significance. To perform a good visual field test, we need to monitor the patient fixation, and the machine is doing this by two methods. The first method is the Hill-Krakow blind spot method. In this method, a slightly bright stimulus is projected to the presumed blind spot that it should presume that the patient will not see that spot. Now, if this patient doesn't see that spot, as in this figure, now this is the patient is fixing, and this is the presumed blind spot stimulus. So if the patient is not seeing that stimulus because it is falling in the blind spot, this is normal, indicate good fixation. However, if the patient like this moving his eye and the blind spot is away, so the stimulus will be seen by the patient. This indicates he has a poor fixation. The other method is the gaze tracking methods, and this gaze tracking method this is more reliable and more precise than the Hill-Krakow method, and it uses a real-time image analysis to verify that the patient is looking to the fixation target. It measures the distance between the pupil center and the cornea reflex. As you can see in this image, there is a light reflex for the pupil, for the cornea, light reflex, and the pupil. So it measures the distance between these two. So since it measures the distance between these two variables, it is independent of the head tilt or head movement. So it is more reliable than the Hill-Krakow method. Sometimes the machine uses both methods to do the fixation. But of course, this will increase the examination time. If you want to shorten the examination time, as in CETA strategy, they stop the fixation error catch trials by stopping the Hill-Krakow blind spot method and just keep or based on the gaze tracking methods. And this slide, how to read the gaze tracker in the Humphrey perimetry. It is made up of light with low irregularities, that is smooth like this. The upstrokes, if the pupil is moved, it has an upstroke. If the pupil is moved, there is no good fixation. However, if the pupil is blocked by blinking or by dropping of the lid, there would be a downstroke like this. So this is a bad tracker. Okay, you can see much fluctuation. This is a little bit good. There is smooth fluctuation, and this is also very bad tracker that is very high fluctuations. Okay. In Octopus perimetry, there is an intelligent tracking system that posts the system when there is poor fixation. For any reason, if the patient blink or dropping of the lid like this, the system will stop projecting light to the stimulus, so the patient will not miss any stimulus. Also, if the head of the patient is retracted back from the contact with the machine, it will be stopped. Or also it determines the light reflex between the distance between the light reflex of the cornea and the edge of the pupil. And if this distance is lost or moved, the system will be stopped, and so on. So it has an intelligent tracking system that it avoids fixation loss, and the system will be paused. That's why you will not find fixation loss in the Octopus perimetry map, because the system will stop by itself, and it will continue once the patient is in a proper position. False positive is one important parameter in the reliability indices or reliability parameters in the perimetry printout. And in the full threshold strategy, false positive means that the machine will produce a sound without initiating any light stimulus. So if the patient is trigger happy, he will press the button as if he has seen the light stimulus. However, he is only based on the listening to the sound. And in the CETA strategy, it adopts a new way that it anticipates the reaction time of the patient. That's the reaction between the light stimulus and the response of the patient. If the patient, for example, his response is within 50 milliseconds and suddenly he responds within 10 milliseconds, now the machine will regard this as a false positive. So this is an important parameter, because it will affect the presence of false positive will affect the better deviation probability plot and the total deviation probability plot, because the patient in the numerical plot, you will find extensive high sensitivity in the numerical data, and this will be reflected back into the glaucoma hemifield. You will find it outside the normal limit, outside the normal, in the mean high sensitivity of the retina. And also in the grayscale, you will find white scotomas, because this is abnormally high sensitive retina, so you'll find white scotomas. Also in the pattern deviation, you will find what's called the reverse scattered pattern, that you will find the pattern deviation probability plot is worse than the total deviation probability plot. This is called reverse cataract pattern. and sometimes you will find even missed blind spot because of the excessive stimulation from the patient. So false positive, if it is more than a particular limit that's around 20%, that you should repeat your test. In this slide, I will speak about the how the machine determine the false positive errors. In this error, the machine will exert a sound without a light, and the patient will respond by pressing that as if he's seeing the light. So this is one way that the machine presses just only a sound and no any stimulus, and the patient will press that he's receiving the light. This is a false positive. This slide shows the impact of false positive errors on the printout, in the perimetry printout. As you know, that false positive means that the machine will produce a sound as if there is a light stimulus, but actually there is no light stimulus. So the patient will keep on pressing as a trigger happy, so this will be reflected back onto the result of the printout. So you will find here in the grayscale a white scotoma here, because the values here will be abnormal, more than the normal range for his age. For example, the periphery will find more than 40 decibel, which is abnormal. So you'll find a white area here, which is mean white scotoma. Also, you'll find the high positive mean deviation above the normal and positive glaucoma hemifield test. And also, you will find that the pattern deviation probability plot is worse than the total deviation probability plot. And that's why, because the total deviation here, the numerical value of the total deviation will be more than normal. So when we subtract the 7th best percentile to extract the pattern deviation, so we will extract large amount from this numerical values. Accordingly, the pattern deviation will be worse. It will be worse as compared to the total deviations. So when you find this finding, that's the total deviation, the pattern probability plot is worse than the total deviation with a white scotoma and the gray scales and above normal range mean deviation and glaucoma hemifield test. This indicates a trigger happy patients or false positive result. And if it is more than 15% here in the catcher trials, more than 15%, you should repeat your test. Otherwise, it will give you an unreliable result. Now, in CETA standard or CETA fast, it assumes another way for detecting the false positive. For example, if we throw a stimulus to the patients, the machine will be able to determine the lag time for the response of the patient, the response time. The response time is around 180 to 200 milliseconds. So in this, the response is a true normal response. Now, if the patient responds before this time, that's in 50 milliseconds and less, this indicates it is false positive. So if it is pressed immediately without seeing the light, so it regards this as a false positive. So this is adopted by CETA. This slide shows the picture of the grayscale when there is a false negative errors. You can see the central area will have this pattern or this appearance, because this represents the first 4 points that we usually test the patient when we start with the patient. So the patient will be concentrating and will respond normally to the first 4 points. And then after that, it will neglect the other peripheral points. So it gives this appearance was called clover leaf appearance. This is the shape of the clover leaf. So this is the shape of the gray scale. It's called clover leaf appearance of the grayscale pattern is to reflect a false negative result. As far as the reliability indices, most of the books, they mention that if fixation loss is more than 20%, regard the test is unreliable. And for false positive, if it is more than 33%, is unreliable and you have to repeat the test. And also for the false negative. But in recent books, most of the recent books, they mention that these values are very high, especially for the false positive. Now, false positive is very dangerous one. So most of them, they say that if the test is more than 20% for either one of them, you should repeat the test. and I mean 20% fixation or 20% false positive or more than 20% false negative, you have to repeat. And even for false positive, some regard even the upper limit is 15%. If it is more than 15%, you should repeat the test, because false positive will is more dangerous, more serious, because it will mask an underlying pathology. So you will notice when you read different books that they mentioned about 33% to be unreliable, but this is a big figure. Now recent books, most of them, they say if it is more than 20%, you have to repeat the test. The third zone here is the numerical threshold plot or numerical data. This is the raw data. This is each point shows the sensitivity of each point of the retina, as you can see here, exactly according to the pattern of the test you use, either 24-2, 30-2, or 10-2. This is 24-2. So it represents the raw data for each and every point in the retina. And you will find figures in positive value and also figures in zero value. Zero value indicate 0 decibel sensitivity, which means that the patient, even with maximum stimulus, he can respond to the stimulus with maximum intensity. And values less than 0 indicate that he cannot see a stimulus with maximum intensity. However, we cannot take decision or conclusion just by looking to this raw data unless we apply some statistical tests that is seen in the next slide. That's the total deviation plot. That's the total deviation plot. Now, this is the numerical plot. In this slide, as I said, that the numerical scale or the numerical data is just the raw data. That's the initial data once the machine finished without any processing, without any statistical application. Now, these data are very important. Now, for example, if you can see this patient, nearly normal numerical data, there is no any minus values, and it looks within range. However, the total deviation numerical plot and the total deviation probability plot is abnormal. Similarly, the pattern deviation numerical plot and the pattern deviation probability plot are abnormal. So there is discrepancy between the numerical data and the data extracted after processing by statistical analysis. So in this patient, there is a mistake in the age of the patient. So that the age of the patient is placed wrongly. So after doing the test, the age of the patient is modified and placed wrongly, so that the numerical data are normal because they are not changed after taking the test. However, all the statistical analysis went wrongly because they compare it with another normative data not comparable with this patient age. So this is one of the important things that you should keep in mind when you find a normal raw data. That's the grayscale, and the numerical data are normal, totally normal. However, the probability plot for the total deviation or the pattern deviation are abnormal. Think that of the mistake placement of the age of the patients. The fourth zone in the perimetry map is the grayscale. And this grayscale is just a graphic representation of the raw material. That's the numerical scale. This is the numerical scale, and this is the grayscale. So just this is a graphic representation of this data is represented here. And as I said, this is the raw data is not compared with any normative data, so we cannot extract any conclusion or diagnosis based on this grayscale. However, it gives you a general information about the status of the patients and is useful in explaining to the patient the situation of his eye. So this is the grayscale. Here I want to just give you a quick and practical points, especially in the exam. When you see the printout of the perimetry, if it is round like this, it is either a 10-2 or a 30-2. Now, what's the difference is the blind spot. Of course, the 10-2, you will not find the blind spot, okay? And the 30-2, you will find the spot. So if you find it round like this, it is either 10-2 or 30-2. If it is octagon like this, like it has 8 faces like this is 24-2. And always the nasal stip is present corresponding to the blind spot. The blind spot always present in the temporal area, and the nasal stip will be here. Okay, so by this you can determine the right or left eye. Of course, whenever the blind spot in the right, this means right eye. If it is in the left, it means left eye. Okay, but the octagon shape means 24-2, and the round shape 30-2 with a blind spot, and the round shape without a blind spot is this 10-2.
Now for zone 5 and zone 6 we'll take together because they are interrelated. The total deviation numerical plot and the total deviation probability plot. As you can see here in this slide, this is the zone 5 and zone 6. This is the total deviation numerical plot. What we mean by this plot, it is the difference between the patient's raw data that we have extracted from the machine and the normative data for his age. So we have a normative data for his age of the patient, and we have the raw data that we have extracted from the machine. The difference between these two will gives you the total deviation numerical plot. Now, after applying a statistical test to identify whether this deviation is statistically significant or not, this is gives you the total deviation probability plot. So this is the total deviation numerical plot, and this is the total deviation probability plot. And the black dots here and the gray spots here, you can see at the end here, this shows you the degree of significance, less than 1% or less than 5% and so on. The smaller the figure, the more significant is the deviation. So when we say that this defect is less than 5% probability, it indicates that less than 5% of the normal people, they have the same defect. So most likely that this is more normal. So this is zone 5 and zone 6. As I said here, that the probability plot here is very important. It shows us the deviation of the patient's data from the normative data. As you can see here, if there is this scotoma indicate less than 5%. And what's the meaning of these figures? Less than 5% indicate that less than 5% of the normal people, they have this finding. So most likely that 95% of the population will be abnormal. So your patient will fall in this category. He either within the 5% that is normal or 95% that is abnormal. Now, if you have this scotoma, indicate that your patient is less than 2%. It means that in the normal people, less than 2% fall in this group, and 98% will be abnormal. And accordingly, so the smaller the figure, the more significant is the deviation. And based on this, we can say that there is an abnormality of the patient. I should remind you here that we cannot give just the diagnosis based on the perimetry map. The perimetry map shows you that there is an abnormality, and doesn't mean that there is a disease. It should be completed along with the clinical finding of the patients. After you finish the examination of the patient of the optic disc and the OCT and the intraocular pressure and everything, at that time you can reach to a conclusion and give a diagnosis. But only based on the perimetry without any other clinical examination, it shows you that there is abnormality here, but we cannot say what disease is there. This should be very clear. Now the seventh zone is the pattern deviation numerical plot, and this is the pattern deviation probability plot. How the pattern deviation numerical plot is calculated, it is just a modification of the total deviation. This is the total deviation. We deduct some value from the total deviation to compensate for any generalized depression in the map. So if there is any depression left here is reflecting a localized depression and a real depression in the sensitivity of that patient. Now, how can we deduct a value from the total deviation here? It is based on the 85th percentile that we calculate the 85th percentile and remove the best 7th point. So the value left will be deducted. I will show it in the next slide in detail. So the pattern deviation numerical plot represent a real focal depression in the retinal sensitivity, and it is a modification of the total deviation. Now, after extracting the pattern deviation numerical plot, we apply statistical tests to extract the pattern deviation probability plot, which reflect that this deviation is statistically significant. And according to the figures here, you can understand this scotoma in black. So the black corresponding number is less than 0.5%. So it means that this is statistically significant. In this slide, I will try to explain how we extract the pattern deviation plot. The pattern deviation plot, this is the total deviation plot for the 24-2, and this is the dashed line is the for the 30-2, and this is the pattern deviation plot. Now, in the 24-2, we have 54 points, and this is the total deviation from the normal data. When we calculate the pattern deviation plot, we remove the initial 3 points that's adjacent to the blind spot. This is the blind spot. So we remove these 3 adjacent points, and so we will left with only 51 points. Now we will arrange this 51 point in ascending manner, and then we will calculate the 85th percentile. And that is to say, we will remove this the first 7th point. That's the best 7th percentile. I will show it in the next slide how to measure it. So, for example, we left with the 51 points. So we will arrange them in ascending order. That's the lowest retinal sensitivity, and go slowly up to this is the highest retinal sensitivity. The 85th percentile, this means that 85% of the data falls below this value. So after we determine this is the 85th percentile. That is to say, removing the first 7th point. This is the best 7th percentile. The best 7th percentile, because we have 51 points, and if this is the 85th percentile, we will left with the initial 7th point. Now, the 85th percentile corresponds to a 3 decibel. This is the sensitivity of the retinal point. This area is a 3 decibel. So what we will do in the pattern deviation plot, we will deduct 3 decibel from all these data. So we'll deduct this 3 decibel so that we will correct for any generalized depression for this data. So the value 3 will become 0, and the value 5 will be 2, and so on, like this. Okay, so this is the way how to calculate the pattern deviation plot, by estimating the 85th percentile and deducting the best 7th points after arranging the points in the ascending manner. This, of course, this is done automatically by the machine itself, but this is to explain you how the machine is work. And this is applicable for the 24-2 and 30-2. For the 10-2, this is something else. There is another calculation. As you understood from the previous slide, that we deduct the 3 points that is adjacent to the blind spot is not calculated. Then we will arrange the remaining 51 points in an ascending manner. Then measure the 85th percentile, which is correspond to the 3. And now you see, now this value after correction becomes 0. 3 becomes 0. And this one become -2. And for example, this 3 will become 0, and so on. Okay, this is the way how to measure the pattern deviation probability plot. The 8th map, after finishing the pattern deviation numerical plot, is the pattern deviation probability plot. It is the same, but after applying the statistical tests to show whether the deviation, this one, is statistically significant or not. Now, the main advantage of the total deviation the numerical plot and the total deviation probability plot, that it extracts and it highlights the localized defect from the generalized depression in the visual field. So when you find this finding, after the correction and removing the best 7th point as explained earlier, so this is a real scotoma and a real depression in the retinal sensitivity. Is not masked by the generalized depression due to cataract or small pupil or any other thing. So this is the pattern deviation probability plot. Now you will read the figure corresponding to each scotoma here, and accordingly you will determine whether your patients is normal or abnormal.
Here I would like to speak about some of the artifacts. It's important that before you give any conclusion or decision or diagnosis, you have to make sure about the reliability indices of your test. The second thing is the presence or absence of artifact. A common artifact usually originated from the lens rim correction of the patients, either high myopia or high hypermetropia, and also for the near corrections, which is used for the near targets, and also the lid artifacts due to lid ptosis or dermatochalesis. Other common artifacts due to unreliability of the test, like false positive and the false negative. You should be aware of these things before you give.
This is another example of some of the artifacts in the visual field. If you can see this patient in the grayscale, there is large scotoma here, and it is corresponding to the lid artifact due to the patient is not seeing the upper part of his field because of his lid. So you should remember this thing. And in this example, you can see here in the numerical plot, there is some values of 0 decibels and some values are less than 0 decibel. And I have explained this before, that when there is a 0 decibel, indicate that with a maximum intensity without any attenuation, the patient can see that light. However, less than 0 decibel indicate that the patient is not able to see a maximum stimulus from that machine. In this slide, you can see the visual field of this patient shows completely normal, except that the blind spot is little bit hanging down. This is called low hanging because of poor fixation of the patients. So this is low hanging blind spot. Now, after we repeat the visual field, you can see the blind spot correctly is located here. So this is named as low hanging blind spots.
The third quiz is what does it mean when you find the pattern deviation plot looks better than the total deviation plot. Now, when you look to this printout, the first impression when you see this is the pattern deviation probability plot and this is the total deviation probability plot, you will feel that it looks better, but this is actually not better, but this represents a local defect in the top of a generalized defect. As we explained before, the meaning of pattern deviation probability plot after the correction for the generalized depression means that this is all these points are depressed, but these points are more depressed than all of these points. This is the meaning of pattern deviation probability plot. So in this scenario, the first cause may be presence of another coexisting pathology like presence of cataract on the top of glaucoma. So the generalized depression is because of cataract, and this is the local defect because of glaucoma. But also can be seen in advanced cases of glaucoma in which there is a generalized depression because of glaucoma, and there is specific areas with marked depression due to the local affection of the nerve fiber bundles. So you will find the combination of both local defect and generalized defect. So we have three scenarios: the relation between the mean deviation and the pattern standard deviation. As you can see here, there is high median deviation. High means high in the negative side. So there is generalized depression, but the contour of the hill of vision is smooth. So the pattern standard deviation is zero value. And in this slide, you can see that the contour is totally irregular. That's the pattern standard deviation is high. However, the mean deviation, which represents the height of the hill of vision, is normal. In this example, like our case here, it's a combination of both abnormality in the mean deviation, that is high mean deviation, and also the contour is irregular, so abnormal pattern standard deviation. So in this slide, I will speak what shall we do to avoid misinterpretation of the 24-2 in case of severe case of glaucoma with marked depression in the retinal sensitivity. You can see here in the 24-2 the pattern deviation numerical plot and the pattern deviation probability plot is not generated and this is because of the mean deviation of the these values, numerical values, is less than 20 decibel. When this value is the mean deviation less than 20 decibels, the pattern deviation numerical plot or probability plot is not generated. This is number one. In this case, you have to go and do the 10-2 perimetry map, and you can see here that the pattern deviation numerical plot is there, and the pattern deviation probability plot is there, and it appears better than the total deviation probability plot. So you will misinterpret that this patient is good, but the answer for this is that you have to look to the all maps together. This is the map for the grayscale and the numerical plot. Now, this is very important that you will find all the values with minus integer or minus values, and this explains why this is better than that one. And as I have explained earlier, the way how we extract or generate the pattern deviation in the 24-2, it differs than the in 10-2. The 24-2, we have 51 spots after deducting the 3 spots adjacent to the blind spot. So we left with 51 spots, and the 85th percentile means that we will remove the 7th best sensitive points, and then we will add the value of the 85th percentile to the all values. However, in the 10-2, we have 68 points. So the 85th percentile will means another figure. It is not the same. That's why in this map is not generated in the 24-2. However, the pattern deviation, numerical, and probability plot is generated in the 10-2. So take home message that in advanced case of glaucoma, you should look for both 24-2 and 10-2, and you should compare the finding all together. That is the grayscale as well as the total deviation probability plot and the pattern deviation numerical and probability plots.
Another important artifact that I would like to emphasize in this slide regarding the visual field index. Now, this is a perimetry map for 3 visits of the same patients. The first visit showing the grayscale and the total deviation probability plot and the pattern deviation probability plot with the visual field index of 64%. And he has a mean deviation greater than 20 decibel. Okay. Now, in the next visit, I noticed that there is a marked drop in the visual field index to 40%. And that was because, and also I noticed that there is no pattern deviation probability plot is generated here. This is because the mean deviation dropped below 20 decibel. And the reason for that was because the test was not reliable because of high false negative results. So the test was not reliable. So it make the mean deviation drop dramatically, and accordingly, the pattern deviation is not created. As I said before, that when the mean deviation drop below 20 decibel, the pattern deviation will not be created. Now, the important point that the visual field index is normally created from the pattern deviation probability plot, and hence the pattern deviation is not generated. So the machine will create the visual field index from the total deviation probability plot, which is markedly reduced in this case. So this alarms a progression. Initially, you think that there is a marked progression in his glaucoma case. However, since the test is not reliable, repeating the test again shows improvement in the mean deviation better than 20 decibel, and hence the total the pattern deviation probability plot is generated. So the visual field index returns to normal. That's 62%. So it initiated alarms of progression, but this was a false alarm, and the patient shown to be stable. This is important to note this fact.
Here I will show some of the common artifact that happens. For example, in the right side here, you can see that this is the visual field of the right eye, and by mistake, the perimetrist examined the left eye. So this is the right eye, but you can see that the blind spot is present in the left. So this is the blind spot of the left eye, and this is the field of the right eye. So this is one of the common mistakes. The other mistake, this is the ring scotoma or rim artifact. It's called rim artifact. due to wearing thick glasses, most likely more than +4 diopter. So this is and should not be interpreted as a concentric generalized depression of the sensitivity of the retina, but this is an artifact due to the wearing of high thick glasses. In this slide, can you determine where is the abnormality? This is the 24-2. You can see clearly here that there is no blind spot. So should this be of concern for you or not? Now, the answer for this question, not necessarily and not all the time, because as you know, the blind spot represent the location of the optic nerve, which is the blind spot located between 12 to 15 degrees temporal to the fixation, and it is 1.5 degrees below the midline. It measures about 5.5 multiply 7.5 degrees. Now, in the presence of a small optic disc or in the presence of hypoplasia of the optic disc, you might the blind spot will falls between the spots of the 24-2, as I said before. The distance between the two spots of the 24-2 is 6 degrees. And if there is hypoplasia of the optic disc or small optic disc, the location of the blind spot might falls within these two spots, so cannot be measured. That's why it is not always of concern when you find that there is no blind spot like this. For example, in this patient, the disc diameter area is 1.25 millimeters, square millimeter, 1.25, which is a small optic disc. A normal optic disc up to 1.8 square millimeter. So this should be kept in mind when interpreting the 24-2. And usually the presence of the blind spot for us differentiate the perimetry map from the 10-2. When you look to the 10-2, you will not find the blind spot. This is one of the features. But the 24-2, the first thing that you will find the blind spot. If you find the blind spot, so this is 24-2. Another thing is the nasal step. Okay. An important parameter in the perimetry printout is the global indices. And by global indices, we mean that we summarize and compress all the informations present in the perimetry printout into a single figure that enable us to compare the result of the successive visits of the same patients over a period of time. And also, if we have a group of patients and you want to select those with, for example, mild glaucoma or moderate glaucoma, you can set up predetermined value of the mean deviation, and accordingly you select your patients. For example, you select patients whose mean deviation between -6 and -12 and like that. So the most common global indices is the mean deviations and also the pattern standard deviations. Now, recently in the Humphrey visual field is added the visual field index. We will speak about each one of them separately in the next slides, but generally the mean deviation is very important indicator of the height of the hill of vision, and it represents the generalized depression. If you find it increase in the minus value, it indicates the increase in the generalized depression. Short-term fluctuation refers to the inter-test variability. That is, when you do the test and the same machine will repeat the test within the same session for 2 to 3 times and find out the response of the patient. If it is within 1 or 2 or up to 3 decibel variables, it is accepted. But if it is beyond that values, it is regarded as unreliable. Pattern standard deviation refers to the local depression in the retinal sensitivity or the visual field sensitivity, and it represents the contour of the hill of vision. So the main deviation represents the height, and the pattern standard deviation represents the contour of the hill of vision. Corrected pattern standard deviation is after removing the short-term fluctuation from the pattern standard deviation, we will receive the corrected pattern standard deviation, and also it reflects the local defect in the hill of vision. Visual field index is an important index that represent the central vision, and it gives an idea about the status of visual acuity of the patients, and also the quality of vision of the patient that affects his quality of life.
As I said, that the global indices represent or give us an idea about the shape of the hill of vision. Now, to describe the hill of vision, we have to describe the contour and the height of the hill of the vision. The contour of the hill of the vision is represented by better standard deviation and corrected better standard deviation. However, the height is expressed by the mean deviations. And as I said, in the theta strategy, you will find only the mean deviation and the better standard deviations. However, the full threshold strategy, you will find also the short-term fluctuation and the corrected better standard deviation. So the first parameter in the global indices is the mean deviation. And as I said, the mean deviation is the mean of the total deviation numerical plots. So it is the mean of the whole data seen in the total deviation numerical plot. And the mean deviation expressed in decibel units along with a p-value. And a positive value indicates better overall sensitivity than the normal, and the negative value indicate a worse. So this is the normative data, and this is the height of the hill of vision. Now, if you have a minus value of the mean deviation, indicate your patient has generalized depression of the sensitivity, and if you have a positive value, indicate it is towards the normal. So this is the mean deviation. So the mean deviation expresses the changes in the height of the hill of vision. The next thing is the pattern standard deviation. Now, the better standard deviation, this is represent the focal irregularity in the hill of the vision. It is the standard deviation of the total values of the total numerical plot. So it indicates the relation between these values, and if there is homogeneous irregularities or homogeneity between these values. So it has 0 to positive value. 0 indicate there is no irregularity, and positive plus value indicate that it is very bad irregularity. The more the plus value, the more the irregularity will be there. So this is the pattern standard deviation. So pattern standard deviation expresses the changes in the contour, and as I explained earlier, the mean deviation expresses the changes in the height of the hill of vision. Same, the pattern. This is the figure shows the pattern standard deviation, and as you can see, this is the normal hill of vision, and this is a focal irregularity. Now, the pattern standard deviation represents this area. That is the focal irregularity. Now, in this patient, you will find decrease in the mean deviation because the height is decreased, and also there is a positive value for the pattern standard deviation because of the irregularity. Okay. So now, if you look to this patient, he has generalized depression, but there is a regularity in the contour. So you will have the pattern standard deviation value is low here, but not as compared to this one. Okay. The fourth index of the global indexes is the short-term fluctuation. And as I said, that this short-term fluctuation is not measured in theta strategy. You will find it in the full threshold strategy. And short-term fluctuation means that there are selected points, about 10 points in the visual field. They are repeated many times, and find out the difference between each reading. Now, if there is 2 to 3 decibel variation between the sensitivity, this is accepted as a patient fluctuation. It is also named as intertest fluctuation or variation. However, if the variation between the reading in the same point is more than that, this indicates unreliability of the test and sometimes due to some pathology. This is called short-term fluctuation. The other index is the corrected pattern standard deviation. It is nothing but it is the pattern standard deviation after removing the short-term fluctuation or short-term fluctuation. So this is called corrected pattern standard deviation. Corrected pattern standard deviation. So it is just the pattern standard deviation after correction and removal of the short-term fluctuation. Also, it represents a focal defect in the contour of the hill of vision, defect in the focal contour of the hill of vision. A very important index in the printout that has been recently added is the visual field index. And the visual field index has a value between 0 to 100, and it has no probability value. It is reflecting the residual central vision of the patient, and it takes consideration of the being more weight for the central sensitivity as compared to the peripheral sensitivity. So it is measured from the pattern deviation probability plot values, and if the mean deviation of the printout is dropped below than minus 20 decibel, so it will be calculated from the total deviation probability plot. So this is very important to take this in consideration, that when the mean deviation of the printout is more than minus decibel, at that time the visual field index may not be that reliable, as it is calculated from the total deviation probability plot rather than better deviation probability plot. It has no probability value, just a figure between 0 to 100. The more the value, the better the prognosis, or the better the quality of the central vision of the patient. Another useful utility of this index is it is very useful in establishing a trend analysis or progression, establishing the progression of the glaucoma. So if you want to follow the patient for over a period of time, you can follow him with the visual field index. So it is very useful tool for assessing the glaucoma as far as the progression is concerned, and also in comparing two visual fields for the same patient or for two different patients or two different eyes. So it is very important parameter in this regard. In summary of the global indices, which represent the summary of the printout of the perimetry, the MS, this is peculiar to octopus. This is the main sensitivity, and in Humphrey it is the main deviation, which is the mean of the total deviation plot, and it has a positive and negative value, plus minus 2 with regarded as normal. Beyond this, either there is, if it is in the plus sign, it is increased sensitivity. If it is in the negative sign, it is decreased generalized sensitivity. Similarly, the pattern standard deviation and the loss variance, which is in the octopus, the pattern standard deviation, this represents focal defect in the hill of vision. And it is the summary of the pattern deviation numerical plot. So we can represent that all of these values by one value, which is normally it has a value between 0 to 6. Up to 6 is regarded as normal. It has no negative value. 0 indicates normal, regular contour of the hill of vision, and the more the plus value indicates some irregularities. And the short-term fluctuation, this is the intertest variability, and it has within 2, it is regarded as normal, and beyond than 2, it indicates unreliability of the test. And the corrected pattern standard deviation and the corrected loss variance, which is in octopus, the corrected pattern standard deviation, also it is a representation of the focal defect, and it has a value of up to 4, from 0 to 4, and beyond 4 is regarded as abnormal. The 10th zone of the perimetry map is the glaucoma hemifield test. And in this glaucoma hemifield test, this is newly added to the printout of the perimetry, and it evaluate and compare 5 zones in the upper hemifield with another 5 zones in the lower hemifield. And normally, usually there is similarity between the upper and lower zones. And accordingly, there is a score system of 5 grades is done based on the deviation of the values of the pattern deviation numerical plot, and each one is compared with the corresponding zone. This is very sensitive and specific test for glaucoma, and it should be mentioned here that the grayscale is very useful in this regard. That gives you a hint to the difference between the two upper and lower hemifields. So if you look to the hemifield, look to the grayscale first, and then you look to the glaucoma hemi field, you will get an idea about the discrepancy and the dissimilarity between upper and lower field. Perhaps this is one of the only advantages of the grayscale, that it helps you to predict the glaucoma hemi field symmetry. So in glaucoma hemifield test, as I said, that it is very sensitive and specific for glaucoma detection. The possible result after we compare the machine will compare the 5 zones in the upper hemifield with another 5 zones in the lower hemifield. The result can be outside normal limits if the difference between any of the 2 points in the upper and lower zones is less than 1% of the normative data. And it is regarded as a borderline if the difference is less than 3% between 2 points in the upper and lower hemifields. And it is graded as general reduction in the sensitivity if the highest threshold is lower than 95%, that's seen in less than 5% of the normative data. And abnormal high sensitivity, that is usually seen in the false positive and the high false positive, when the highest threshold is the higher than 99.5% seen in less than 5% of the normal population. So there is increase in the sensitivity in 1 point by more than 99.5% of the normal population. And within normal limits, if the above 4 criteria are not fulfilled, it is regarded as a normal. So this is how we interpret the glaucoma hemifield. From the glaucoma hemifield test, Anderson set a special criteria named as Anderson criteria for glaucomatous visual field that's helpful in the early diagnosis of glaucoma. Initially, when Anderson invented this criteria, it was not modified. It was done on the standard threshold strategy in the 30-2 visual field. However, now in recent machines, they are using the CETA standard strategy and using the mainly 24-2 perimeter. So it is changed to the modified Anderson criteria, that each student in the postgraduate should be aware of this criteria. That's very useful application of the glaucoma hemifield for early detection of glaucoma. This criteria indicate or state that glaucoma, when you find glaucoma hemifield outside the normal limit, and 3 or more non-adjacent points on the 24-2 printout, 2 of these spots have a probability value of less than 5%, and at least one with a probability value of less than 1%. So it is 1%. And the third criteria is the pattern standard deviation should be abnormal and should have a p-value of less than 5% or 3%, and so on. So these are criteria. If you find this criteria, so this is more in favor of glaucoma. This is named as modified Anderson criteria. This is an example of the visual field effect that is confirmed by the pattern deviation probability plot, and all the criteria of the Anderson criteria are fulfilled. That is more than 3 non-adjacent, 3 non-edge points that is away from the central line. They are in clusters, and at least one of them less than 1% probability and the others 5% probability. This is more in favor of abnormality that's suggestive of focal defect, most likely due to glaucoma. And here I should emphasize on that your duty is to determine whether there is an abnormality that is statistically significant or not, and never give a diagnosis just based on the perimetry printout. After determining the abnormality, and you say that statistically abnormal, now you should go and compare this finding with the clinical finding. What's named as a structure function relationship. That's, you have to look to the fundus, you have to look to the OCT, and see if this finding in the visual field is associated with the changes in the fundus or in the retinal nerve fiber layers in the OCT or not. and that's because the changes in the visual field are very late. Usually the changes in the nerve fiber layer will appear first, and the functional changes that's in the visual field appears later. So if you find a patient like this, that's to say he has abnormality in the function. So there must be a changes in the fundus, and there must be a changes in his retinal nerve fiber layer. So never give a diagnosis just based on the perimetry printout. You should look to the patient as a whole. You look to the OCT printout, and look to the optic disc and the cup and the nerve fibers as a whole. So after that, you can reach to a final diagnosis.